Hi everyone, my name is Nagamanoj Pamadigantu, and my project asks a simple question. Can symptoms reported early in leukemia treatment help predict which children may be at greater risk for serious side effects later? To investigate this question, I built and tested a machine learning model that combines both symptom reports with basic clinical information. Introduction. Leukemia is a cancer of the blood and bone marrow, and it is one of the most common cancers diagnosed in children. Chemotherapy can be very effective, but it can also cause serious side effects, including pain, fatigue, nausea, infections, and emotional distress. My idea was to combine both machine learning with information reported directly by patients. The problem. Two children can receive similar treatments but have completely different experiences. One child may have manageable symptoms, while other may have severe side effects that affect their health and even interrupt their treatment. Doctors already use lab results, medical history, and their own experience to estimate risk. However, surveys completed by patients or their families are not always used to predict what may happen next. That creates an opportunity. Could the patient's own experience provide an additional early warning sign? Patient-reported outcomes. Patient-reported outcomes, or PROs, are reports about symptoms provided directly by the patient. For younger children, guardian or parent may sometimes help report these symptoms. Pro surveys can ask about pain, fatigue, nausea, emotional well being, and sleep. These reports are important because lab results can measure things like blood counts, but they cannot always show exactly what the child is going through. For my project, I decided to use early pro responses as inputs for a machine learning model. Research question. My research question is, can baseline and week 1 PRO mixed with basic clinical information identify simulated pediatric leukemia patients at increased risk during the following 30 days? My hypothesis was that great higher or worsening symptom scores early in treatment would be associated with greater toxicity risk. For this study, I used 3,000 simulated pediatric leukemia records. I want to be clear that no real patient data was used. The records included age, treatment phase, clinical history, and symptom assessments from baseline and week 1. The PRO inputs included pain, fatigue, nausea, sleep difficulty, loss of appetite, and problems with daily activities, and changes from baseline. The model job was to classify each simulated record as either high risk or lower risk for simulated toxicity outcome during the following 30 days. This classification would be an alert for further review for the doctors. It would not be a diagnosis or an automatic treatment decision. How the model works. I used 2,400 records to train the models while keeping 600 records completely untouched for final testing. I also used five-fold cross-validation, which basically means that I repeatedly trained and evaluated each model on different portions of the training data so that the result would not depend on only one split. I compared three machine learning models: logistic regression, random forest, and gradient boosting. All three performed similarly, but logistic regression had the highest mean cross-validation, rock AUC at 0.896, random forest scored 0.893, and gradient boosting had 0.889, which basically means that logistic regression had the strongest result and it was also relatively interpretable. So as a result, I selected this for my final model. How the models did on the untouched simulated data. When I evaluated the final model on the 600 untouched simulated records, it had a ROC AUC of 0.915. ROC AUC may sound complicated, but the basic meaning is if I selected one random higher risk record and one lower risk record, the model would rank the higher risk record above the lower risk record about 91.5% of the time. This is not the same thing as saying the model had 91.5% accuracy. The model also achieved 92% sensitivity, which means that it identified 161 of the 175 simulated higher risk cases. It had missed 14. Its specificity was 71.3%. It correctly classified 303 lower risk records, while 122 lower risk records received false alerts. For this type of screening model, I prioritize sensitivity because missing a genuinely higher risk child could be more serious than generating an extra alert for the doctor to review. Important symptoms. Next, I looked at which inputs had the greatest influence on the model. I did this by shuffling each input and measuring how much the model's ROC AUC decreased. If shuffling a variable caused a larger decrease, that means the model depended a lot more on that variable. Week 1 nausea had the greatest influence. Changes in activity interference, fatigue, and sleep difficulty were also pretty important. This does not prove that nausea or fatigue causes toxicity. It only shows that within this simulated dataset, those variables were useful information for the model's prediction. Impact. This machine learning model can help doctors find high risk children earlier. This would let doctors observe the patient who are in higher risk more closely, order more tests, adjust the treatment if necessary, and help the patient's quality of life. But this model can only support judgments. I want to make it clear, it cannot make any treatment decisions on its own. The biggest limitation for this model was that the records and outcomes were both simulated. Real pediatric cancer information is private and protected, and publicly accessible datasets connecting leukemia, PRO surveys, and toxicity outcomes are really difficult to obtain. Therefore, the model's performance has not been demonstrated in real patients. The results show that the machine learning process works in a controlled simulation, but they do not prove that it would achieve the same performance in a hospital. Real world validation would be required before any clinical use. Conclusion and future directions. In conclusion, early PRO symptoms allow a logistic regression model to distinguish between higher risk and lower risk simulated records, producing a ROC AUC of 0.915 and sensitivity of 92%. The biggest takeaway is not just the score, it is the information reported directly by children and families could potentially be treated as meaningful predictive data instead of being used only to describe how a patient currently feels. The next step would be to work with hospitals and pediatric cancer researchers, validate the model using real de-identified data, and continue comparing and improving different machine learning methods. If this approach is successfully validated, it could also be expanded to other childhood cancers. Ultimately, listening to patients earlier may help clinicians recognize risk earlier and respond earlier. Thank you for listening.